So hello friends, I think you all can hear me and see me. Just give me a thumbs up that you all can see me and hear me. I'll just wait for everyone to come. So if you guys can see me and hear me, just give me a thumbs up so that I can start. Okay. Chalo, before coming to the So before coming to today's topic, that is the odontogenic cyst and tumor, first let's discuss what and all are topics which are very important with respect to oral pathology and which are most frequently asked in the exams. Okay, so we have odontogenic cyst and tumor. So this is the most important topic of the oral pathology because majority of the questions they do come from odontogenic cyst and tumor. Infections. So in infections, we have bacterial, viral, and fungal. Now, infections you will be covering in detail in your microbiology class. Then salivary gland pathology, developmental anomalies, skin path, bone path, neoplasia, and few of the miscellaneous topic. Okay, so we will go in this order. First, we will cover odontogenic cyst. Okay, so should we start odontogenic cyst? Shrestariya, should we start? Now coming to the odontogenic cyst. Okay, so before coming to the odontogenic cyst, let's first understand what is cyst. Okay, so this cyst, it is derived from cystis. It is derived from cystis. Now what is cystis means? It basically means a sac or bladder like. It means a sac or bladder like. So coming to the definition which is given by Kramer. Okay. So cyst definition which is being given by Kramer, it is a pathological cavity. That means some pathology is associated. It is a pathological cavity which contains, now this pathological cavity, it can be either fluid, semi-fluid or gases, but not pus. Remember, this pathological cavity, it should not have pus. If there is a presence of pus, then it will be called as abscess. This pathological cavity which contains either fluid, semi-fluid or gases, but not pus. If there is a presence of pus, then it will be called as abscess. Okay. Now this cyst, it is frequently lined by epithelium, but it is not always true. So based on presence or the absence of epithelium, the cyst is divided into true cyst and pseudocyst. So what do you mean by true cyst? Here the true cyst, the epithelial lining will be present. There is a presence of epithelial lining. While pseudocyst, there is no epithelial lining. No epithelial lining. So let's just understand this with a diagram. It will be much more clear. So for any cyst, it has three parts. It has a lumen, it has an epithelial lining, and it has a connective tissue capsule. Okay. So true cyst, so as you can see in this image, it has a lumen. Okay, there is a presence of lumen. Epithelial lining is present and it is surrounded by a fibrous connective tissue. But this is a pseudocyst where there is no epithelial lining. There is a lumen which is surrounded by a connective tissue lining where there is no epithelial lining. Okay, now this cyst can occur anywhere in the body, but cyst which arises from the odontogenic apparatus, it is called as odontogenic cyst. So cyst from odontogenic apparatus it is called as odontogenic cyst. While all other cysts which are derived other than the odontogenic apparatus, these will be called as non-odontogenic cysts. So any cyst other than odontogenic epithelium, these will be called as non-odontogenic. Now, odontogenic cyst, it is a type of true cyst. Okay, that means there is a presence of epithelial lining. Odontogenic cyst, it is a type of true cyst. Okay, so we know that true cyst, there is a presence of epithelial lining. Okay, true cyst, that means there is a presence of epithelial lining. Now coming to the, what is the source of this epithelial lining? So source of the epithelial lining will obviously from the structures which are involved in the development of tooth. Structures involved in development of tooth. So what are the structures involved in the development of the tooth? You would have done this in your DA, DH. Okay. So we have reduced enamel epithelium. Okay. Remnants of HERS. What are the remnants of HERS called as? It is called as cell rest of molasses. So I think you guys just have finished your DADH, so you can answer me, okay? You can answer me on the telegram, remnants of HERS, it is called as cell rest of molasses. While dental lamina remnants, these are called as dental lamina remnants, answer. These are called as cell rest of Serre. Okay. So the source of the epithelium for the odontogenic cyst, it can be either reduced enamel epithelium, HERS, or the dental lamina. So we have our first classification of odontogenic cyst is based on the source of epithelium. That is, what is the source of epithelium? So first classification is based on source of epithelium. Now this is very important. Okay, this is very important. Your direct MCQ question will be based on this. Okay, that what kind of cyst is developing from what kind of developmental structure of the tooth. Okay, so cyst derived from reduced enamel epithelium. So which cyst will derive from reduced enamel epithelium? It is dentigerous cyst and eruption cyst. Dentigerous cyst and eruption cyst. Cyst derived from dental lamina. It is OKC, odontogenic keratocyst, gingival cyst, lateral periodontal cyst, glandular odontogenic cyst, and calcifying odontogenic cyst. So is this clear? Is this clear? So cyst arising from reduced enamel epithelium, it is dentigerous cyst and eruption cyst. Dental lamina, we have OKC, gingival cyst, lateral periodontal cyst, glandular odontogenic cyst and COC. While the cyst which is derived from HERS, also called as remnants, these are called as cell rest of molasses. So these are radicular cyst and residual cyst. Okay. So residual cyst, it is a type of radicular cyst. Residual cyst. Okay. So first classification, it is based on source of epithelium of that particular cyst. Okay. Now the present 2017 classification, it was given by WHO. Now this is also very easy classification. Now this classification, it is based on etiology. It is based on etiology. So it is a very easy classification. They have divided cysts into inflammatory and developmental. So if you guys have any doubt, you can just comment on the Telegram session and I'll take care of it. Okay. Inflammatory and developmental. So in inflammatory, we have radicular cyst, and inflammatory collateral cyst. Very easy to remember. Inflammatory collateral cyst. While all other cysts apart from radicular and inflammatory collateral cyst, it will come into the developmental category. Okay. So now one type of radicular cyst we have discussed, it is residual cyst. And then inflammatory collateral cyst, there are two types of inflammatory collateral cyst. It is pardental cyst and buccal bifurcation cyst. Buccal bifurcation cyst. Apart from all these cysts, it will come into the developmental category. Okay. Now this classification is very important. In fact, both the classification, because your direct MCQ question will be based on this classification. So in developmental, we have dentigerous cyst, OKC. A variant of OKC, it is orthokeratinized odontogenic cyst. Orthokeratinized odontogenic cyst, lateral periodontal cyst, glandular odontogenic cyst, calcifying odontogenic cyst, eruption cyst, botryoid odontogenic cyst, gingival cyst of newborn and gingival cyst of adult. And gingival cyst of adult. Now, till COC, that is your dentigerous cyst, OKC, orthokeratinized odontogenic cyst, lateral periodontal cyst, glandular odontogenic cyst, and COC, these are intraosseous. Intraosseous means present within the bone, okay? While your botroid odontogenic cyst, gingival cyst of newborn, gingival cyst of adult, eruption cyst, all these are extraosseous. That means present in the soft tissue. I hope this is clear. Both the classification, that is epithelium, what is the source of epithelium, and the etiology of the WHO classification, that is your inflammatory cyst and developmental cyst. Okay. So just have a revision. In inflammatory, there is a radicular cyst and inflammatory collateral cyst. Apart from all these two cysts, all other cysts will fall under the developmental category. Okay. Now coming to the one-liner MCQ, which is very, very important. One-liner MCQ. Now tell me, which is the most common cyst? Most common odontogenic cyst. Which is the most common odontogenic cyst? It is radicular cyst. It is 60 to 65%. Now tell me, which is the most common inflammatory odontogenic cyst? Most common. Just see the classification. This is the inflammatory. Most common inflammatory odontogenic cyst. Again, the answer will be radicular cyst. Now, if the question says which is the most common developmental odontogenic cyst, then your answer will be dentigerous cyst. Okay, remember this. Dentigerous cyst. So as you can see in the classification, if they have asked about the developmental, then in developmental the most common is the dentigerous cyst, not the OKC. It is dentigerous cyst always. Okay. Now, I know I have not discussed about this, but since we are discussing about the one-liner, we can discuss it. Which is the most common developmental non-odontogenic cyst? Odontogenic cyst. So most common developmental non-odontogenic cyst, it is median anterior maxillary cyst, also can be called as MAMC or nasopalatine cyst. Nasopalatine cyst. So till now we have discussed what is cyst, what is odontogenic cyst. Odontogenic cyst, there is a presence of epithelial lining. Then we classified the cyst based on what type of epithelium is present. Then the second classification, it was based on WHO, which was in 2017. So I hope till now it is very clear. Then we will start discussing about each cyst one by one. Okay. So coming to the inflammatory cyst. Inflammatory cyst. Okay. So in inflammatory cyst, we will discuss first radicular cyst. Now radicular cyst, it is the most common odontogenic cyst. Okay. It is most commonly seen in maxilla, Most commonly seen in maxilla. Now tell me, what is the source of epithelium? What is the source of epithelium? We have just discussed. Source of epithelium is the HERS. Okay. That is called as cell rest of molasses. Now what happens for the radicular cyst? There has to be some inflammation. When the tooth is having some kind of inflammation because of dental caries or trauma, what it will does, it will stimulate this Hertwig's epithelial root sheet or the cell rest of molasses. Okay, so which in response to inflammation, there is stimulation of HERS. This HERS will get stimulated, leading to the proliferation of HERS. So this is the pathogenesis. Pathogenesis of radicular cyst. That means some inflammation has to be there for radicular cyst. Now this radicular cyst, it is also called as apical periodontal cyst. It is also called as apical periodontal cyst. Why periodontal? Because periodontium is involved. It is also called as root end cyst because it is present at the end of the root, and it is present in the periapical area of the tooth. It is also called as periapical cyst. Periapical cyst. Now this radicular cyst, it is always associated with non-vital tooth. Remember, radicular cyst, it is always associated with non-vital tooth. Non-vital tooth. As a result of inflammation occurs as a result of caries, decay, dental decay, or because of some trauma, leading to the non-vitality of the tooth. Now patient will be asymptomatic. Patient remains asymptomatic and will not respond to the EPT or the thermal testing. No response to EPT or thermal testing, which confirms that the tooth is non-vital. Okay, so let's have a look on the diagram. It will be very clear. See, because of some carious structure or because of some trauma, here the HERS got stimulated and leading to proliferation and ultimately leading to the radicular cyst. Okay, so let's discuss the phases of the cyst formation. Phases of cyst formation. This phase is very important because MCQ question have been asked from this topic. Okay, so first there is initiation of cyst. Initiation of cyst followed by proliferation. Followed by proliferation. Proliferation. First, let's write down the phases, then we will understand this with the help of diagram. Okay, initiation of the cyst followed by proliferation. Then there is a phase of cystification. Cystification. Then there is a stage of growth and enlargement of the cyst. Growth and enlargement. Okay. Now what happens in the first phase, there is stimulation and the proliferation of HERS. Okay. So here, can you see there are a lot of cells which are proliferating. Now what happens when the lot of cells will proliferate, the center cells will get devoid of nutrition and this will undergo ischemic necrosis. Ischemic necrosis, or also called as liquefaction necrosis, and there will be formation of lumen, and this lumen, it will contain fluid. Okay, so in the second phase there will be formation of lumen and it will have a fluid, which is followed by stage of cystification. Cystification. Now what will happen for the cells? The cells surrounding this area, it will break down. Further cells will break down, and what they will do, they will release protein. Now this protein, it will increase the osmotic pressure. I'll write it. Further cells will break down and what they will do, they will release protein. They will release protein. Now this protein, when it will be released, it will cause increase in the osmotic pressure. It will increase the osmotic pressure. To balance out this osmotic pressure, the fluid will come inside. Okay, there is ingress of the fluid. Ingress of the fluid, which is followed by stage of cyst growth and enlargement. Cyst growth and enlargement. So when the cyst will grow and enlarge, what it will do? It will resorb the bone which is present in the surrounding area. Now tell me, which is the interleukin which will be responsible for the bone resorption? When the cyst will grow and enlarge, there will be resorption of bone. There will be resorption of bone. Now interleukin, which helps in the resorption of the bone, it is interleukin 1 and interleukin 6. Very important MCQ question. Okay. Now coming to the radiograph of the radicular cyst. See, radicular cyst, radiographically it is seen as well-defined radiolucency associated with non-vital tooth. Okay, associated with non-vital tooth. Now, in both the radiographic image, there is a well-defined radiolucency which is present. Now, based on radiograph, we can say that periapical granuloma, it is smaller in size, while cyst is larger in size. But remember, we never differentiate cyst and granuloma based on radiograph. Okay, make it as a point number 1 that we never differentiate cyst and granuloma based on the radiograph. We always differentiate based on the histopath. So histopath is the gold standard. Now tell me, what histological feature we will see in the radicular cyst, which will not be seen in the granuloma? In a radicular cyst, there will be presence of epithelial lining, as it is a true cyst. Epithelial lining will be present, while in granuloma there will be no epithelial lining. But if the question says that based on the radiograph, yeah, we can say that granuloma, these are smaller in size, while cysts, these are larger in size. Okay. Now in latest Schaeffer edition, it is said that CBCT may provide accurate diagnosis. Accurate diagnosis. So if in your option, if CBCT is mentioned, then we will mark CBCT. That means that they have taken that question from the recent Schaeffer's edition. Okay. Now coming to the periapical abscess. Now this periapical abscess, this is also associated with non-vital tooth. So make it a point, periapical abscess, granuloma and radicular cyst all are associated with non-vital tooth. That means the tooth is dead. But in the periapical abscess, what radiographic feature will be seen? It will be ill-defined radiolucency. Ill-defined radiolucency, while granuloma and cyst, it has a well-defined radiolucency. See, this is a periapical abscess. It is a ill-defined radiolucency associated with non-vital tooth. Okay. Now coming to the histopath of the radicular cyst. Okay. So radicular cyst, it is a type of true odontogenic cyst derived from cell rest of molasses, and it is associated with non-vital tooth. Histopath is very, very important. Okay. Now epithelium. Epithelium here is non-keratinized stratified squamous epithelium. Are you guys with me? Is everything clear? Non-keratinized stratified squamous epithelium. If you guys have any doubt or you want me to repeat anything, you can just write on the Telegram and I will take care of it. Okay. Epithelium. Now interface. So let me just open the diagram. Okay. So epithelium, it is non-keratinized stratified squamous epithelium. So for this, as we discussed, there is a lumen, there is the epithelium and the connective tissue. Okay. So now see, this is the epithelium and this is the connective tissue. Interface between the epithelium and the connective tissue here, it is not straight. It is not straight. As you can see, there are thin proliferating reti ridges is present. Okay. So in the histopath, what do we see? Thin proliferating reti ridges. Proliferating reti ridges. Now you would have heard many times about the arcading pattern. Okay. What is arcading pattern? The interconnected network of proliferating reti ridges It is called as, now these proliferating long thin ratty ridges, these are interconnected. That means these are intertwined with each other, leading to the formation of arcading pattern. So this is arcading pattern. So arcading pattern, it is not pathogenomic for the radicular cyst. Arcading pattern, it is also seen in radicular cyst, residual cyst, which is again a type of radicular cyst, residual cyst, and inflammatory cyst. Very easy to remember. All the inflammatory cysts will have the arcading pattern. Inflammatory collateral cyst. Now, when we aspirate this radicular cyst, what do we see? Cholesterol crystals. Cholesterol crystals. While on histopathological slides, what do we see? We see cholesterol clefts. Cholesterol clefts. Now, these cholesterol crystals, they impart shimmering effect. They impart shimmering effect. See, these are the cholesterol crystals which is giving a shimmering effect. Now, these are the cholesterol clefts. Okay, these are cholesterol clefts. These cholesterol clefts, these are surrounded by multinucleated giant cell. Now, remember, we will see in what other cysts do we see multinucleated giant cell. So, this is the first cyst, okay, in which multinucleated giant cells are seen. Now, majority of the questions will be asked from this multinucleated giant cell. So on histopath, cholesterol clefts, these are surrounded by multinucleated giant cells. Multinucleated giant cell. Okay, now just make it as a point number 1 that multinucleated giant cells are also seen in this. Now the other histopath, in the lining epithelium. In the lining epithelium, linear arc-shaped calcifications are seen. Arc-shaped calcifications are seen. What are these linear arc-shaped calcifications? These are called as Rushton bodies. Rushton bodies. Now, what are these Rushton bodies? These are refractile but not birefringent. These are curvy, linear, arc-shaped, eosinophilic, hairpin-shaped or C-shaped bodies which are seen as calcification, and more importantly, where it is seen in lining epithelium. Can you see? Tiny arc-shaped, hairpin-shaped present. These are seen as calcification in the lining epithelium. These are eosinophilic, hairpin shaped, C-shaped bodies seen in the lining epithelium. Now, Rushton bodies are again, these are not pathogenomic for only for the radicular cyst. These are also seen in let's just write down first in the radicular cyst, periapical granuloma, dentigerous cyst, and OKC. Now, why I am telling you that these are also seen in all other cysts? Because your question can give all these options and then they will ask all of the above. So your answer will be all of the above. Remember, Rushton bodies, these are seen in radicular cyst, periapical granuloma, dentigerous cyst, and OKC. Now, what is the source of this Rushton body? Source. All these have been asked in your paper, okay? Rushton body. Now, it comes from breakdown of RBC. There is a breakdown of RBC because of the hemorrhage in the cyst. Due to hemorrhage in the cyst, or they are seen as a secretory product. Secretory product. Now, these Rushton bodies, these gives a Rowley phenomena. Okay, if they are present as a secretory product, it gives a Rowley phenomena. Which is a very important MCQ question. Okay, Rowley phenomena is shown by which bodies? They will give you many bodies, Rushton bodies, ghost cells. The answer is Rushton body. Now, coming to the Russell body. Russell body. These are also eosinophilic, but these are round. These are round cells. Round eosinophilic. Round eosinophilic. And here the nucleus, it is present in the eccentric part of the cell. Round eosinophilic with eccentric nucleus. Eccentric nucleus. And when we see in the higher magnification, it gives a cartwheel appearance. Cartwheel appearance. These are formed by plasma cells. What are these? These are basically the collection of immunoglobulins. Formed by plasma cells. What are these? These are collection of immunoglobulins. These are collection of immunoglobulins. Now, these Russell bodies, when these are present in the multiple myeloma, these are called as Mott cells. In multiple myeloma, these are called as Mott cells. Okay, so I hope the difference between the Russell and the Rushton bodies is clear. See, these are the Russell bodies. These are round, eosinophilic, and the nucleus is present at the eccentric part. Okay. Now, coming to the types of the radicular cyst, okay, which is important. Now, see, this is the radicular cyst. Okay. Now, what is this? This is a lateral variant of the radicular cyst, okay, which is called as lateral radicular cyst. lateral radicular cyst. Now this will always be associated with non-vital tooth. All the radicular cysts, it will always be associated with the non-vital tooth. Now this occurs because of the presence of the lateral or the accessory canal. That is why it is present lateral to the tooth. Due to presence of accessory canals, so the infection through this accessory or the lateral canals, it has gone towards the lateral part of the tooth. That is why it is present lateral part of lateral surface of root. Now, very important MCQ question. Whenever I discuss the lateral radicular cyst, I always discuss the lateral periodontal cyst. Now, this question was asked in the recent November INI paper about the lateral periodontal cyst. And they have just asked which cyst is most commonly associated with the lateral which is most commonly associated with vital tooth. So remember, lateral periodontal cyst, it is always associated with vital tooth. We will discuss lateral periodontal cyst later, but since we are discussing the lateral radicular cyst, just for now, remember, lateral periodontal cyst, will be always associated with vital tooth. So this question was asked in the INI November 2023. Okay, now variations of the lateral radicular cyst. Okay, so we have periapical, I'll write it, variations of radicular cyst. So we have periapical, pocket cyst, and base cyst. Base cyst and periapical true cyst. Okay, so let's discuss this with a diagram. Okay, so this is a base cyst, periapical base cyst. This is a periapical true cyst. Now you tell me what is the difference between the base cyst and a true cyst. Now can you see here the epithelial lining? Here the epithelial lining, it is incomplete and there is extension of the root into this lesion, while in the true cyst, it is present as a isolated bag-like structure in which there is no association of the root with the lesion. Okay, adjacent to the tooth and it is separated from the tooth. Okay, it is present at the apex of the tooth. Now this is the only difference between the base cyst and the true cyst. Okay, here the root is extending into the lesion, while here it is an isolated bag-like structure. Okay, I hope this is very clear. Now coming to the residual cyst, which we discussed, it is a type of radicular cyst. It is a radicular cyst associated with extracted tooth socket. Or we can say that there is no presence of teeth or absence of tooth. Now when the tooth was extracted, some residual pathology still remained inside, leading to the formation of the cyst. This is called as residual cyst, because some residual pathology which was left behind and later developed into cyst. Okay, now a question can be asked as well-defined radiolucent lesion, okay, seen and associated with extracted tooth. So the answer will be residual cyst. Okay, so histopath will be same as radicular cyst, while radiographically, tell me what will be the radiographic feature? No tooth, because there is absence of the tooth. No tooth. So this finishes your radicular cyst. So everyone, please give me a thumbs up if radicular cyst is clear, so that we can move on to the inflammatory collateral cyst. So after the inflammatory collateral cyst, we will take a 10 minutes break. Okay, then we will start with dentigerous cyst. Inflammatory collateral cyst. Now in 2017, WHO 2017 classified the inflammatory collateral cyst in the paradental cyst and buccal bifurcation cyst. Paradental cyst, it is associated with partially, remember paradental cyst, partially, okay, so you can remember this in this way, partially impacted mandibular third molar. Pericoronitis can lead to this. Pericoronitis can lead to the paradental cyst, and histopathologically it is similar to the radicular cyst. While the buccal bifurcation cyst it is associated with erupted mandibular first molar. This is paradental cyst, partially impacted third molar. Buccal bifurcation cyst, erupted mandibular first molar. Now it is most commonly it is seen in buccal part of the tooth. Distal is very rare. Distal is rare. Now there is buccal extension of the enamel in the furcation area. Buccal extension of enamel in the furcation area. Now this can lead to the formation of periodontal pocket. Periodontal pocket. Just remember, paradental cyst, it is associated with partially impacted third molar. Buccal bifurcation cyst, it is associated with erupted mandibular first molar. Okay, so this finishes your inflammatory cyst. That means we are done with the radicular cyst. Inflammatory collateral cyst again, which is divided into buccal bifurcation cyst and paradental cyst. Okay, then we will start with the developmental odontogenic cyst, and the most common developmental odontogenic cyst, it is the dentigerous cyst. Okay, so we will have a 5 minutes break. Then we will start with the developmental odontogenic cyst.